Good evening, everyone, and welcome to tonight's CANIBD webinar. My name is Jen, and I will be your moderator this evening. Before we begin, though, I just have a few housekeeping items that I'd like to share with everyone. Firstly, if you could try to submit your questions in the chat box that's on the bottom right of your screen. We'll be collecting all of those questions and answering them at the end of the presentation. Secondly, everyone should be receiving a post-webinar survey after tonight's presentation, and we kindly ask that you all take just a few moments to complete this. It really does help us plan for future events and make any improvements that you feel we could do better with. Thirdly, I'd also like to remind everybody of the upcoming CANIBD conference as part of the Meeting of the Minds meeting in November. I understand there are a few spots still left on the Saturday afternoon program, so if any of your colleagues are interested in joining us, please encourage them to go online and register. Also, I'd like to take a moment to thank our sponsor tonight. Ferring has been very generous in supporting this event, and we again like to thank them for their support. I'd also like to thank Emily Cordeau, who is our coordinator with Crohn's Colitis Canada. She has been extremely helpful in organizing all of our webinars and getting us through this in a timely manner. So thank you very much, Emily. And last but not least, I would like to introduce our speaker. But before that, I just want to point out that CANIBD is a community of practice for nurses across the country. We are a community of practice within the Canadian Association of Gastroenterology Nurses and Associates and are supported by Crohn's Colitis Canada. Our vision is to ensure that people of all ages living with IBD do receive very high quality clinical nursing care as part of a multidisciplinary team. CANIBD is committed to improving the quality of care for people living with IBD by providing mentorship and learning opportunities for IBD nurses in Canada, creating opportunities for networking and sharing of best practices, developing and adopting nursing guidelines and standards for nursing in Canada, and ultimately elevating the profile of IBD nursing in Canada. So next, I have the great pleasure of introducing our speaker for tonight's webinar. He probably needs little introduction, but Dr. John Marshall is a professor of medicine and the director of the Division of Gastroenterology at McMaster University. As well, he is a consultant gastroenterologist at Hamilton Health Sciences in Hamilton, Ontario. He completed his BA and MD at Queen's University and then undertook his residency training and Master's in Science in Clinical Epidemiology and Biostatistics at McMaster University. He is a full member of the Francoum Family Digestive Health Research Institute. His publications include over 200 academic papers and book chapters and over 200 abstracts. Dr. Marshall is the editor-in-chief of the Journal of the Canadian Association of Gastroenterology. Thank you very much, Dr. Marshall, and I'll hand it over to you.
Great. Well, thanks very much, Jennifer, for that kind introduction. I'll add my thanks to CCC as well as Ferring for organizing this. I'm going to speak to you about this topic of microscopic colitis. And I suppose I should also thank all of you for choosing to do this rather than line up at your local marijuana dispensary today, as most of the Canadian population is doing. But I thought I'd talk about microscopic colitis and more than meets the eye, because this is a diagnosis which, as we'll discuss, is really based on biopsy, not on visual changes when we do colonoscopy. And I always think that microscopic colitis is sort of the forgotten sibling in the family of inflammatory bowel disease. We spend a lot of time talking about Crohn's disease and ulcerative colitis, but this is another variant of inflammatory bowel disease, which in some patients can be challenging to manage, and we'll talk about all of that. I will point out that microscopic colitis actually has some Canadian history. Some of you may know Hugh Freeman, who is a gastroenterologist in British Columbia. And in fact, he in 1976 was one of two groups who almost simultaneously described this phenomenon. Title of his paper on the left was this watery diarrhea syndrome with a lesion in the colonic basement membrane. He published in the same year, this Swedish group published a paper identifying this phenomenon of collagenous colitis with watery diarrhea. So really around the same time these two papers were published, but we'll assume that this was a Canadian discovery. If you look through history, some of the terminology evolved in the 1980s, and this terminology of microscopic colitis first came about when Reed characterized a cohort of patients who had this chronic diarrhea syndrome. And then also in the 80s, Lazenby noticed that the intraepithelial lymphocytes were a hallmark feature of microscopic colitis, and so he introduced the term lymphocytic colitis to our vocabulary. And so really, this what we call microscopic colitis, to be clear, really comprises two variants. One is collagenous colitis and lymphocytic colitis. So both collagenous and lymphocytic colitis are variants of microscopic colitis. So when we talk about microscopic colitis, we're really talking about these two conditions. But there's been a lot of debate over the years whether these are truly discrete entities or whether they're kind of different ends of a spectrum of the same disorder. As we'll discuss, they're very similar in their presentation, in their epidemiology, and in their treatment. And those of you who've seen these patients in clinic will know that often the biopsies from different parts of the colon may fulfill criteria for both diagnoses. In some places it's lymphocytic, in some parts of the colon collagenous. And indeed, there are case reports out there where someone's initially diagnosed with collagenous colitis, and then later on when they reinvestigated, it looks more like lymphocytic colitis. So it's possible that patients move back and forth between these two entities. So just to start about what microscopic colitis looks like in the clinic, certainly the hallmark feature would be watery diarrhea, not bloody diarrhea, watery diarrhea. So it's always non-bloody. And of course, any diarrhea can be associated with urgency, and in some people with compromised pelvic floors, incontinence as well. Fairly high proportion of patients, when this is active, complain of crampy pain. They may experience some weight loss, and I don't know if it's well explained why, but patients will also complain of some arthralgia, but that's not certainly required for diagnosis. I think something that's fairly typical of microscopic colitis is that it has a chronic relapsing course. It can come and go over time and can disappear for long periods of time. And in a way, that always makes us look like heroes because we give people a treatment and they get better, and we always think that it's our treatment, but it may well just be the natural course of the disease waxing and waning over time. Of course, our challenge diagnostically is that of course this can look just like diarrhea predominant irritable bowel syndrome, and it can be very hard to discriminate the two. And the endoscopic appearance is normal. Some would argue maybe there's very subtle edema and a bit of redness, but that's pretty subtle, and often I think most often it looks completely normal, and hence the term microscopic colitis. So, we often see people who've been investigated maybe at another center. They had a colonoscopy done, it was normal, so they get told this is IBS, but in fact the endoscopist had not taken biopsies of the colon, and so this could be missed. So it's, when we do colonoscopy, people with diarrhea, even if it looks normal, always take biopsies, largely to look for this phenomenon. Importantly, this microscopic colitis has a favorable natural history, so it doesn't progress to cancer, and I think people need to hear that. And it's completely unrelated to Crohn's disease and ulcerative colitis. So it's not just that someone will show up with this and then a year later it turns out to be Crohn's disease. Technically, these are very separate clinical entities. But on this slide is the patient, the typical patient who would be affected. And as we'll look at some of the epidemiology in a few slides, you'll see that this is a female predominant diagnosis and it's age related. So the typical patient with microscopic colitis would be a 60-year-old female. So if you see a 60-year-old female with recent onset of watery diarrhea, this should always be in your differential diagnosis. I always like to find something a little odd about these conditions, and I'll point out that this may not be unique to humans. There are other mammals out there, including whales, and there's this report of a bunch of melon-headed whales in Florida who were stranded, and they died of malnutrition, and at autopsy they all had a variant of Collagenous colitis, which looked very similar to the human entity on biopsy, and a bunch of other things as well. I have no idea whether this is related to what we see in humans, but maybe it's the same phenomenon. Maybe in the future we'll learn something about some environmental exposure common to whales and to people. But what about the epidemiology? I mentioned this before. This is one of the better studies looking at how common this phenomenon is. This is from Olmsted County around the Mayo Clinic in Minnesota, probably the most studied population on the planet. Very good population-based health records. And as of the end of 2010, they noted that there are 234 residents in Olmsted County with that diagnosis. And if you do the math, that works out to 200 per 100,000. So that'd be about 1 in 500 people with that diagnosis. So not as common as inflammatory bowel disease, which is about 1 in 200, but not that far behind. And so if the city of Hamilton has 500,000 people living in it, then there'd be 1,000 people with microscopic colitis. It's fairly evenly split between lymphocytic and collagenous colitis. And you can see, if you look at gender, it's 3 times more likely in women than men. I have to say, in my clinical experience, it seems even more heavily skewed towards women. Very rarely have I seen true microscopic colitis in a male. And the other thing is the increasing prevalence with age. So you can see that it's relatively uncommon below age 45, more common between 45 and 65, and as you get beyond age 65, even more common, about 500 per 100,000. So that's getting up to about 1 in 200 women over age 65. So that was the prevalence, so the number of existing cases in the population. This slide looks at the incidence, which is the number of people who would be newly diagnosed with microscopic colitis per year. And in fact, this slide shows a systematic review of the literature from 25 studies. And you can see that each collagenous and lymphocytic colitis each has an incidence of about 5 per 100,000 cases per year. So between them, 9 or 10 new cases per 100,000 each year. So again, if you think about a city of Hamilton, 500,000 people, there'd be about 45 or 50 new cases each year. So each gastroenterologist in Hamilton probably sees a handful of new diagnoses each year. Again, just like the prevalence is predominantly female, so is the incidence. 2 to 3 times more women than men developing the new diagnosis. And the median age at diagnosis is again in the 60s, although there is a range. And as you go up in age, the incidence becomes higher. This is just another way of showing this increase in incidence with age from Olmsted County. So one of the papers that was included in the meta-analysis in the previous slide, and you can see relatively uncommon below age 40, and then it certainly becomes much more common starting at age 60. So both age and gender are risk factors. And this looks at the epidemiology of collagenous colitis over time, and you can see that it seems to be becoming more common, more diagnoses over time. You know, I graduated medical school in 1992, and it was a relatively new newly described phenomenon, even though, in the 70s someone had described cases of this, but it really wasn't common in practice in the early 90s, and it's become a much more common phenomenon in our clinics. And of course, hard to know why this might be. Lots of potential reasons. It could be that it's truly becoming more common. A lot of autoimmune inflammatory phenomena are increasing in incidence for reasons we don't understand. But I have to think maybe we're doing more thorough investigation. We're more aware of this diagnosis, so we do more biopsies. And I suspect that pathologists in interpreting biopsy specimens are calling this more often than they used to because of greater awareness. But maybe it's increasing in prevalence, but I think it's also an increase in awareness over time. So I thought I'd show you a picture of what this looks like under the microscope. So this is a very typical biopsy from a patient with Collagenous colitis. And I don't know that I can use my cursor. I'm not sure if you can see this, but there is this pink layer underneath the mucosa, underneath the epithelium. That's collagen deposited, and it's really an instant diagnosis when you look at a biopsy. Technically, at least 10 microns in thickness, but that would be Collagenous colitis. And often the biopsies are stripped because probably because this is a bit fragile. So in the processing, sometimes the epithelium is kind of pulled away and separated from the rest of the biopsy. So you might see that stripping phenomenon, they call it. But also, there would be typically an increase in lymphocytes within the epithelium, and usually other inflammatory cells as well. But it's the collagenous collagen band and the IELs which are the characteristic features. This slide shows you a typical picture of lymphocytic colitis, which I can tell you looks very similar, except it doesn't have the collagen band. It's a normal collagen layer, but a lot of these lymphocytes have increased IELs, intraepithelial lymphocytes again, and there's a minimum number that you'd like to see, and again, also other inflammatory cells as well. So this is what it looked like, and this is what the pathologist would be looking at to make a diagnosis of microscopic colitis. So how do you diagnose? Well, it's pretty simple. You need a colonoscopy and you need to do multiple segmental biopsies. The literature is not really very firm on whether where the changes are most common in the colon, and you'll see different suggestions in different papers where people looked at different cohorts of patients. But there is a suggestion that the collagen thickening can be more obvious in the right colon. So that's one of the reasons for requiring a full colonoscopy, not just a flexible sigmoidoscopy, to make a diagnosis of microscopic colitis. Now, an important thing is that this condition would not elevate fecal calprotectin levels much, if at all, because the inflammation is largely lymphocytes. And I think many of you know that calprotectin, in fact, comes from the different white blood cell, the neutrophil, which is present in other kinds of inflammation, including Crohn's disease and ulcerative colitis. But lymphocytes really don't contain calprotectin. So when they turn over, you don't get the elevated fecal calprotectin level that we often use in practice in following people with Crohn's and colitis. And this is a bit of a challenge because, there's a literature suggesting that people have diarrhea and have normal calprotectin. Well, they probably have irritable bowel syndrome, but this would be an exception to that. So, again, a woman of the right age with diarrhea, you do a calprotectin, you think, it's normal. There's probably no point in doing a colonoscopy. That may not be true, and you should be aware of this possibility. So why does it happen? Well, whenever you see a busy slide like this with lots of possibilities, you know that we don't really know the answer. But a few things are out there. One is certainly that there may be a genetic predisposition and a number of different genotypes, which in various papers have been linked to microscopic colitis. I don't think any of these is really confirmed. You certainly wouldn't use these as a diagnostic test. But there's some suggestion that maybe changes in how people handle collagen, how the barrier function of the epithelium functions. And there are some specific profiles when people look at the white blood cells and the lymphocytes that are elevated, maybe more CD8 positive ones, maybe more of these specific markers like CD45 Rho or KIT 67 markers, which look at proliferation, and lower levels of this Treg compared to inflammatory bowel disease. And again, I'm not an immunologist, but is a suggestion when that happens, the white bloods, the lymphocytes, are probably not traveling to the gut from somewhere else like they do in inflammatory bowel disease, but they may be proliferating in the gut, and perhaps maybe in response to some local antigen stimulation. But this is very theoretical, and I wouldn't take any of this away as a proven mechanism for developing microscopic colitis. So I think the answer to this slide is we don't know. But what might be driving this? Well, this could be autoimmune, certainly, and there's a higher prevalence of other autoimmune disorders in people with microscopic colitis. And we'll talk a little later about celiac disease, but also thyroid disease, diabetes, Sjogren's syndrome has not been linked to autoimmune liver disease. And also, there are a lot of cases where it seems that this begins after an acute infection, perhaps with one of the bacteria listed here. But this is really tough literature to interpret, because you can imagine the scenario of someone who's had a bit of diarrhea over time, has an infection that leads to healthcare consultation, they get referred, they end up getting a colonoscopy, they do biopsies, and they find lymphocytic colitis. And they say, aha, the infection caused it. Well, the infection probably brought that person to medical attention and brought that patient to a colonoscopy that may not have otherwise happened. So you don't know whether it's just because they get more testing done or whether it's truly the bug. There are also some papers that suggest that there may be a seasonal variation in incidence, a little more common in summer and fall, at least in one small cohort. So maybe that speaks to an environmental exposure. But again, there's really no proven environmental trigger for microscopic colitis. Smoking may be associated, and there are some studies suggesting that smoking is more common in both collagenous and lymphocytic colitis, and particularly current smokers, not reformed smokers or quitters. And in a smoker, it may begin 10 years earlier, so maybe smoking accelerates the onset of microscopic colitis, but it doesn't seem that smokers do any better or worse than non-smokers after diagnosis with respect to treatment or response to therapy. So there may be a relationship to smoking, and of course, any reason to encourage people to stop smoking is a good one, so we should probably cancel our patience on that. Apologize for the phone in the background here. Medications are another issue, and I think that's worth some discussion, because there's been a lot of thought that medications may trigger microscopic colitis, and there's a long list of things on this slide. You can see all of these have been linked in one or two papers to the diagnosis, but I'll focus on a couple NSAIDs and PPIs, because again, I don't think the link is proven, but there is a lot of debate and a lot of evidence to suggest that NSAID and PPI exposure are at least related to the diagnosis of microscopic colitis. So this, again, more Canadian content. This was a paper that was published by Bob Riddell, who some of you may know as a pathologist. He was in Hamilton, then in Toronto, probably the most famous GI pathologist in the world, I would say. I think the bottom of the screen, at least on my screen, is cut off, but this was published in 1992. And this was a small study, only 30 patients with collagenous colitis, but he did a case control study, matched them to similar patients with IBS or diverticular disease, and made the observation that NSAID use was much more common in the collagenous colitis group than in the controls, and then proposed that NSAIDs were a cause of collagenous colitis. And that small paper really led to that becoming seen as true and accepted, that it was always NSAIDs, and we spent a lot of time taking people off NSAIDs with that diagnosis. Well, I'll fast forward a bit, and this was from 2015, so a few years ago, a Dutch population-based study using a big primary care database. They identified over 200 microscopic colitis cases, had of course a large number of controls, and they also had a cohort of patients who had had a colonoscopy which was normal and were the same age and gender as the microscopic colitis patients. So they were called colonoscopy negative controls. And I'll show you in a couple slides why that might be an important comparator. But they looked at medication use in the last 2 years. And when they compared the community controls to microscopic colitis patients on the left, you can see that NSAIDs, PPIs, aspirin, ACE inhibitors, and SSRIs were all linked to a diagnosis of microscopic colitis. Whereas when they compared to people who'd had a normal colonoscopy, only NSAIDs and PPIs emerged as significant independent risk factors for microscopic colitis. And I think the right side might actually be a more relevant analysis. And I'll show you in a couple of slides. Another study looking at risk factors for collagenous and lymphocytic colitis. And again, this was published just about 5 years ago. And again, not just drugs, but other behavioral things. So this is one of the studies that showed smoking to be a risk factor, other autoimmune problems like arthritis to be a risk factor, and then PPIs, aspirin, beta blockers, and other various things, Zoloft, angiotensin receptor blockers, and oral hypoglycemics. But it was really the autoimmune disorder, smoking, and a PPI in this study. But again, the NSAIDs didn't emerge as a risk factor in this large database. So this paper is actually more recent, and this is actually published this year in Elementary Pharmacology Therapeutics. Big Danish study looking specifically at PPI exposure to try to drill down on that one risk factor for both collagenous colitis and lymphocytic colitis. And interestingly, compared to people who've never used a PPI users were at higher risk of microscopic colitis. And for reasons which I don't think are explained, really the strongest risk was with lansoprazole, which is Prevacid, much higher risk than the other PPIs. And the previous slide I just showed you, lansoprazole was also singled out as a risk factor for collagenous colitis. So maybe there's a story there, but we don't yet know. The problem with all these papers is, of course, people with gut symptoms often end up being investigated and found to have microscopic colitis. And people with gut symptoms often end up getting put on medications like PPIs. So you never really know whether this is truly a causal relationship, or whether it's just that people with bellyache end up getting more colonoscopies and also end up getting more PPI therapy. But this relationship exists, and some would suggest that we should take people off PPIs with the diagnosis of microscopic colitis. So this, just to show you this other study, I could show you many of these, but this is another one of these case control studies, this one from Denmark, over 5,000 microscopic colitis patients, each matched 100 controls. That would mean there are about 500,000 controls they compared with. And again, this relationship was there, that PPI use was linked to a diagnosis of microscopic colitis, both for collagenous colitis and for lymphocytic colitis. But the interesting thing, too, in this paper was that PPI therapy was also associated with having a colonoscopy with normal biopsies. So the bottom line is that PPI exposure is probably a risk factor for having a colonoscopy, which was either normal or showed microscopic colitis. And when they redid the analysis and took into account that people on PPIs also had more colonoscopies, the odds ratios became much lower, and they were no longer significant for lymphocytic colitis. So 3.37 went down to 0.95, 7 went down to a 2. So a lot of the effects seem to be explained that patients with GI symptoms got more colonoscopies, and then some of them got a diagnosis of microscopic colitis. So again, I show you this because I'm not sure that these are true cause-effect relationships. There's certainly an association, but I'm not quite sure that PPIs are the cause. I show this paper because a group put together a scoring system to try to help diagnosis in the clinic. This is based on UK population. They suggested that these risk factors be considered: female gender, age over 50, PPI and NSAID use, weight loss, and abdominal pain being a negative, because in general, abdominal pain might point to other diagnoses. And if the score is greater than 8, that was predictive of a diagnosis of microscopic colitis. And so maybe they could be more selective in who they sent to endoscopy. I'm not sure I'd be using this in practice, because basically just being over 50 gives you a score of 13, which is greater than 8, and using an NSAID gives you a score of greater than 8. So I don't think that's enough to really make a diagnosis, but you might use some of these factors in targeting who you want to do colonoscopy and if they present with diarrhea. So we have to talk about gluten. So gluten may play a role. There is a clear association between celiac disease and microscopic colitis. So a third of celiac patients have features of microscopic colitis. And if you go the other way, patients with microscopic colitis, 2 to 9% have positive changes on biopsies, duodenal biopsies suggestive of celiac disease, and up to 4% will have positive celiac serology. So there's a relationship both ways. And in fact, there's this phenomenon we call collagenous sprue, which is a really severe version of celiac disease, where you got collagen deposits not only in the colon, but also in the small bowel. And so if you do a colonoscopy in these patients, it looks like collagenous colitis. And it can be a very challenging form of celiac disease to treat. Doesn't respond often to gluten restriction. So always, when you see one, think of the other. If you make a diagnosis of microscopic colitis, that patient should be tested for celiac disease. And you have a patient with celiac disease who's got a lot of diarrhea and is compliant with their gluten restriction, then they should have a colonoscopy to look for microscopic colitis. So it really should go both ways. And this is an important, I think, point to take home. Well, how do we treat microscopic colitis? I'll show you this because really there's not a lot of evidence for most of these therapies, and so you can put them all in a cauldron and see what happens. A lot of this is based on observational data more than clinical trials. But I'll show you where the evidence sits with the clinical trials. And again, this is the good witch, showing what the perhaps appropriate advice might be for a patient with microscopic colitis. Always think about other potential causes for their symptoms, as we would in practice. Modify diet and lifestyle. Avoid things that can make diarrhea worse. Never miss a chance to tell someone to stop smoking. And if you're a believer that NSAIDs and PPIs are risk factors, then consider stopping those. And you can give symptomatic treatment. Remember, microscopic colitis does not progress to Crohn's disease, does not progress to cancer, does not lead to other nasty things. So as long as you control the diarrhea, you've done a good job. So you can just treat these people with simple things like Imodium rather than treating the inflammation itself. It's perfectly acceptable in this condition. But these are some of the smaller trials, just to get these out of the way, for some interventions. And all of these, except for a small trial looking at Pepto-Bismol versus placebo, all of the others were negative trials on this page. They didn't show a significant benefit. The bismuth trial, the Pepto-Bismol trial, where it's bolded here, that was a study of 9 patients, so 4 in one arm, 5 in the other. So I'm not sure you can put much value on that, but technically it was a positive trial in favor of Pepto-Bismol. But really the mainstay of treatment is budesonide. So this is a clinical trial that was published looking at collagenous colitis. Randomized trial, well done. It compared budesonide 9 milligrams a day versus 5-ASA versus placebo in patients with collagenous colitis. And the budesonide won. You can see for their primary endpoint at the top left in the intention to treat analysis, which is the most rigorous one, the benefit of budesonide over 5-ASA was statistically significant, and the difference between budesonide and placebo was not statistically significant, but numerically significant. And in some of the other analyses looking at secondary endpoints, that difference between budesonide and placebo was also statistically significant. So, this was, I think, favorable for use of budesonide as a treatment for collagenous colitis. And just this year, in fact, this is still in press in Gastroenterology, only published online. This was a very similar trial looking at budesonide for treatment of lymphocytic colitis, so the other kind of microscopic colitis. And to cut a long story short, again, budesonide was significantly better than placebo. And in this example, 5-ASA was somewhere in the middle. So a positive trial for treatment of lymphocytic colitis as well. There is a Cochrane review. It's been updated last year by Nilesh Chandy from London. And 5 trials in all looking at lymphocytic and collagenous colitis treated with budesonide. And the bottom line is that for both indications, there's a significant benefit in favor of treatment, both for clinical response, that's resolution of symptoms, and also for normalization of the histology so that the collagen band becomes thinner and the lymphocytic inflammation goes away. I will mention that the budesonide formulation that was used in these clinical trials is typically an ileo-release formulation, but not the one in Canada, which is Entocort. It's actually typically budenofalk, which is a European formulation of budesonide for ileo-release. There's an appealing argument that budesonide MMX, which we have in Canada, might be a good therapy for microscopic colitis because it does have colonic release, and of course, this is a colonic inflammatory process. So certainly budesonide MMX doesn't have an indication for use in this condition, but it's become something that we often use just because in theory, its release profile matches the distribution of the inflammation in patients who have microscopic colitis. This shows you the trials for use of budesonide MMX in true ulcerative colitis, which is not what we're talking about. But there are some case series out there of using MMX budesonide for treatment of microscopic colitis. And these are relatively small series, but in fact, the table I've shown you is a series of 12 patients, and the other is a case report. But they showed some favorable results, so it's a reasonable consideration for patients who have microscopic colitis that we use either this formulation or the ileo-release formulation. Budesonide doesn't always one treatment with budesonide, not surprisingly, doesn't necessarily keep people in remission. And this is a study showing that about 60% of patients after an 8-week induction course of budesonide did relapse. And that's perhaps not surprising. This is a chronic relapsing disorder. So, it's not surprising that it would come back another time, even if you treated one flare. And so there are some studies looking at maintenance therapy, specifically with budesonide. This is one example, using a lower dose, 4.5 milligrams a day. And you can see that the patients who were maintained on budesonide tended to stay well over time and were less likely to relapse than the patients who were followed up with placebo. Now, I'd say we don't routinely maintain people on budesonide. I would typically give people an 8-week course of 9 milligrams a day if they're unwell, and then stop treatment. But we do have selected cases where it keeps coming back and we keep retreating them, and I think those people may be better off on continued therapy with low-dose budesonide. For the ileo-release formulation, with 3 milligram tablets, that would be either 3 or 6 milligrams a day. We don't have a 4.5 milligram formulation in Canada. And so again, a Cochrane review looking at maintenance therapy. There are actually 3 trials which have looked at this, and I won't go through the details, but again, there was benefit for budesonide maintenance therapy in maintaining remission. What about other therapies? Well, people have done all kinds of things to people who who keep requiring budesonide or who don't respond to budesonide, but we're getting into limited numbers and observational data. But this is the larger cohort I'd show you, where they've had some fair experience with use of thiopurines, methotrexate, a couple of patients with calcineurin inhibitors, that'd be like cyclosporin or tacrolimus, and 10 patients in this series who required anti-TNF therapy. And again, there are patients in these cohorts who responded to all of these therapies where they'd failed to respond to other treatments. So these are options to consider, but I would say that they're rarely needed for microscopic colitis. Lastly, there may be a role for surgery, a very small role, again, I can't say that I've ever sent someone to surgery for treatment of microscopic colitis, but there is experience out there, and this was a particular series of 9 women who had collagenous colitis, which did not respond to therapy. They all got stomas, diverting stomas, ileostomy in 8, the colostomy in 1. Interestingly, all of this seemed to be helpful. And when the colon was diverted, the collagen layer went back to normal, and the inflammation resolved. And the most interesting one would be the patient who had a colostomy, because above the stoma, the collagen stayed thick, but below the stoma in the defunctioned distal colon, the collagen band went back to normal. So maybe something to do with a luminal antigen in the fecal stream. But unfortunately, all of these patients, when they closed the stoma, they kind of got unwell again. So it's certainly not a permanent solution. But if someone's becoming particularly dehydrated, dealing with diarrhea and incontinence, perhaps a diverting stoma would improve their quality of life. But I would consider it a permanent thing, not a temporary thing. So this is an algorithm published earlier this year. This is actually Jeff Nguyen in Toronto is a co-author on this. So just in closing, maybe take you through this. How would you manage these patients? Well, we make a diagnosis at the top, of course, with colonoscopy. If someone's mildly unwell, you may just try to take away triggers. Maybe that includes NSAIDs and PPIs, and maybe just treat them with an opiate antidiarrheal like Imodium or cholestyramine, perhaps. Whereas if they're more moderately unwell, you give them treatment with budesonide for 8 weeks at 9 milligrams a day. And you could think about other second-line therapies, Pepto-Bismol, maybe 5-ASA, maybe cholestyramine. The evidence is less robust for those interventions. Also remove precipitating factors. If they respond to budesonide, and you wouldn't commit to maintenance therapy, but if they relapse when you stop budesonide, yes, you could consider up to 6 milligrams a day as a maintenance therapy over the following year. If they don't respond to budesonide, well, then you have to go back to your scratching your head thinking about other causes of diarrhea. If you can't come up with them, those are the patients where you might consider immunosuppressive therapy. So just to summarize, microscopic colitis is a common clinical entity. I said about 1 in 500 in the population. Its etiology is still unclear. We don't really know what causes it. Possible that PPI and NSAID exposure plays a role, but I wouldn't consider that as proven for the reasons that we discussed. And really, symptomatic therapy, antidiarrheal therapy, and oral budesonide are the mainstays of treatment for induction and maintenance. And that the other therapies are really reserved for particularly rare and refractory cases. So that, I'll show you a lovely picture of Hamilton, Ontario, and I'm happy to answer any questions.
Thanks very much, Dr. Marshall. That was excellent. Answered a lot of questions I'm sure we all had, but I still see a few popping up. If you do have any questions, please post them in the chat box on the bottom right, and we will get to them. The first one I did receive was a question about why is there a higher prevalence in females with microscopic colitis?
Well, I don't know. I mean, that's the answer. I mean, I think if we knew what caused it, then we might be able to figure out why that cause would be more of an issue among women than among men. I think I'd be guessing. We all know that there is a higher prevalence of other autoimmune conditions in women than in men. So maybe this is just another autoimmune phenomenon, which has some gender bias. But beyond that, I have never seen a really cogent explanation for why this is true. It's just one of those phenomena that we just know to be true, but I don't think can really explain.
Okay. We also have one that was texted over to me asking if there's a role for the low FODMAP diet as a treatment option for microscopic colitis.
Mm-hmm. Well, again, I don't think there's any evidence. There's no data on that. No one's ever done a clinical trial of that particular dietary intervention in microscopic colitis. And, I don't know that there's any evidence that FODMAPs would be a cause of microscopic colitis. But when you talk about symptomatic treatment, any kind of dietary restriction that improves symptoms would be reasonable. FODMAPs, I think, are most related to high fermentation, gas production, pain, related to excess gas and fermentation. Those would be the patients where you'd think to use it most. But I will, of course, if you think what a low FODMAP diet restricts, it does restrict intake of gluten. So de facto, if you put someone on a low FODMAP diet, their gluten intake goes down. So I suppose in an undiagnosed celiac patient, that may improve things. But you would also be testing them for celiac disease. There's no harm in putting them on a low FODMAP diet, but I'm not sure that it's specifically suited to this diagnosis.
So I guess that your kind of comment there leads to our next question, is that would you put all patients on a gluten-free diet automatically?
I would say no, but I would test all patients for celiac disease. That's, I think, the mandatory thing. Consider that diagnosis, because you've got a large pool of undiagnosed celiacs in the population. And as you know, untreated celiac disease has a lot of long-term health consequences. So that would be the main message to take away. Now, having said that, if they don't have celiac disease, might they feel better on gluten restriction? I suppose they might, but there's no evidence specifically in microscopic colitis that that's the dietary intervention to consider.
Okay. We have a real busy group in Burlington. They put another question forward. They're asking, why does it tend to occur more in the right colon than in the left?
Well, you know, I don't know. I mean, these are phenomena which have been noticed, and it's not consistently so. I mean, I mentioned that there are some studies which suggest there's a bit more on the right. There are other studies that say that we don't see that. But it can be patchy. I think that's the main message. So just doing a sigmoidoscopy looking at the rectum and sigmoid may not be sufficient to rule out a diagnosis of microscopic colitis. But why? I don't know. I mean, I suppose you could conjecture if it is true that it's more common in the right colon, maybe it does relate to some dietary antigen, which is higher exposure in the right colon. But I don't think anyone really knows the answer to this. This is one of these things that has been poorly studied. There aren't a lot of large cohort studies on microscopic colitis, and because it tends to be more of a nuisance than a life-threatening condition, I don't think it's attracted the volume of research that Crohn's disease and ulcerative colitis have. So I'm not sure that there are big labs around the world really working on the etiology of this, unfortunately. So we're very good at maybe describing what some of the phenomena, but trying to explain why is a difficult one.
Okay, well, that's great. I have a comment that the Burlington group would like to thank you for a very informative presentation, and I would certainly echo that. This is something that I think, as you mentioned, has lacked a lot of conversation, and we see a lot of it, but we run into trouble with how to manage it, and you've given us a lot of good strategies to take home with us. So thank you very, very much. I don't see any other questions, so I just had a couple more comments before we left. I just wanted to thank Dr. Marshall and Fehring for tonight's presentation. As well, I'd like to tell everybody that we're looking forward to seeing them in November at the CANIBD meeting. And also stay tuned to your email, as we'll be having future webinars later this year, and we've already prepared some exciting presentations for January. So stay tuned. Thank you, everybody, for attending, and we'll see you next time. Good night.
Thank you.